Healthcare is insanely expensive. I don't think anyone will argue about that. The question is, how can we make healthcare less expensive? And it got me thinking that if we had some of the best entrepreneurs in our country work on this problem, what solutions would they come up with? And then I saw something from not only perhaps the best entrepreneur in our country, but also the most controversial. And I thought, well, that'll make a great podcast episode. So let's do it. I'm talking about Elon Musk and this concept that he has that's called the idiot index. On this episode, we're going to talk about how we can apply the idiot index to healthcare, why healthcare is so expensive in the first place, and how we can fight back right now. I'm Dr. Nolan Fisher. This is Second Opinions. Let's get into the episode. So first off, what is the idiot index that Elon Musk came up with? Well, he actually came up with this whenever he was developing SpaceX, and they were building rockets. And the first problem that he saw with our current NASA-run rocket spaceship program was that it was way too expensive. And so he started looking at the parts of the individual pieces of the rocket that cost the most. And particularly, he wanted to find pieces that cost a lot of money that didn't seem like they should cost that much. So he came up with something called the idiot index, which was basically the cost of the individual part divided by the overall cost of the basic materials that go into that part. And in Walter Isaacson's biography on him, he talked about the specific situation where there was a rocket nozzle that cost $13,000. Elon Musk looked at it, saw the weight of the aluminum that it was made out of, and figured that it was probably made of about $200 worth of aluminum. Whenever he did this, he then went to manufacturers to see if they could make it lower and they could bring down the price. And when he couldn't find someone that would bring down the price for him, he eventually just had a team come in and develop it within SpaceX on their own. This got me thinking of several different things that I've seen in medicine. But before I explain how this applies to that, I want to talk about a specific case that I saw in my clinic. And that was a patient that I ordered an MRI of his low back. Whenever I ordered the MRI of his low back, I put the order in the computer, they go and get it, right? When he went to get his MRI, he actually got a quote with his insurance that was going to cost over $2,000. When he asked him what the cash price would be, it was roughly around $250. When he saw that discrepancy, he obviously came back and told me, it's like, hey, you have to tell your other patients about that. And so still to this day, I tell patients that if they do want to pay cash, not only can they get the MRI sooner because they don't have to wait for insurance approval, but it's going to cost substantially less. Now, obviously, this isn't the case whenever you've paid down your whole deductible and the insurance will cover the MRI. But for a lot of people, this is a much better way to go about getting an MRI, especially when it comes to cost. This isn't the only example, though, that I've seen of this. And when I went digging to see what things were highest on the idiot index, I want to tell you what else I came up with. The first example I want to do is normal saline. Normal saline is the most common fluid used in the hospital. It is, when you think about getting an IV, it is most likely going to be normal saline. Normal saline is sterile water with a little bit of salt put into a sterile plastic bag and then shipped out and then used to put it into your veins. The average cost for this to make is between 50 cents and $1 per bag. Bags of normal saline in hospitals and emergency rooms routinely will cost $150 to $300 when billed through insurance, making the idiot index on this somewhere between $150 and $300 if you're doing $1 cost for the materials. Another example would be generic medications. So a lot of medications that are used for like high blood pressure, conditions like that have been around forever, they're generic and they're made dirt cheap. Whenever they're pressed into pill form and sent out, they can cost as little as 10 cents per pill to make. After PBM upcharges, so pharmacy benefit managers, which we'll talk about later, and insurance companies, these same pills can cost up to $40 a pill at pharmacies for patients with insurance. So that's a idiot index of 400, if I did my math right. Another thing I want to talk about, and this is a slightly different situation, but still a medication, are infusion centers where physicians administer drugs that are oftentimes chemotherapy drugs. There's a medication that's called Neulasta, and the role of this medication is to fight off infections during chemotherapy because chemotherapy depletes your immune system and therefore makes you vulnerable to them. Neulasta will be billed roughly at $4,000, $4,500 for Medicare. If you look at the cost to make this medication, it's much lower than that. But when you compare that to what the commercial insurers are paying, that can be up to $55,000 per dose. So even though the idiot index on that may only be roughly 10 times, the overall cost difference is $50,000 per dose for a medication that's used very widely. And then if we go to a different medication that's been talked about as far as cost goes, I'd probably say the second most common one that's talked about next to Ozempic, and that's insulin because it's essential and it can be very expensive and recently has gotten more expensive. Insulin in the United States regularly costs 5 times more than other countries. So even if that's just the baseline idiot index we're working off of, that's still very high. And then it's not just, you know, bags of saline and medications and infusions that we're talking about here. We're also talking about devices, implants, and particularly with cardiac devices, this is very common. So cardiac stents and implantable cardiac devices like pacemakers and stuff cost us in the United States 2 to 6 times more than a country like Germany that has worked to bring these down. So now that we've talked about the idiot index and all those, you see how rampant it is. This spreads across all specialties, inpatient, outpatient treatment, imaging centers, medications, pharmacies. Your natural assumption when you hear this is that the hospital is just marking up these treatments in order to make more money. And this is true. They are marking up the treatments because they do need to make more money. But it's not just out of greed. You see, the hospitals, on average, if you average out all the hospitals in the United States, they're losing money every year. The operating margins are negative, meaning that they rely on charitable donations to even stay operational. Even then, the most successful hospitals run razor thin margins and they have to do this in order to stay in business. So if we did this and we, took away the idiot index and we lowered all these prices, the truth is that the hospitals would just go out of business. So we can't do that. What we need to figure out is where is this money going, right? Because if you're not spending that much on medications, it must be going somewhere, right? And the truth is, there is an arms race going on, and there's an arms race between hospitals and the people who are paying them. And the people who are paying them are not directly patients, it's insurance companies. You see, hospitals spend billions of dollars per year that goes towards people who are billers, coders, auditors, and lawyers. These billers and coders are responsible for taking physician services and notes and making sure that they are maximizing what they bill, make sure it fits the information and guidelines from the insurance so that they get paid. And then that will maximize how much they get for providing those services from the insurance. The auditors are responsible to make sure that that physicians and the billers and coders aren't leaving anything on the table. And then the attorneys are in the background making sure that they're drawing up the best contracts and making sure that none of the rules are getting violated with this process. There's also administration. So administration, this includes compliance people, legal people, and executives, has grown at an exponential ratio compared to the growth of actually people who provide care for patients in the hospital. You could also group into this software that's going to the hospitals. So like the electronic medical record is the big one. The software medical record is meant not as a way to pass on information about patients. It's meant as a way to bill for more money. And finally, it wouldn't be fair to bring up the billions going to collections and administration without talking about cross subsidization. So, cross subsidization just means that people who have commercial insurance are paying for the other people who come into the hospital. There is a thing called EMTALA, which means which was set up to ensure that anybody that shows up to an emergency room or hospital and needs to get taken care of, regardless of their insurance status, will get taken care of. As a result, there are billions of dollars in expense every single year from people who don't have insurance that show up at a hospital and they can't pay for it. And the hospital ends up delivering this care without ever getting paid, and they call it charity care. And so that can be up to 10% of what hospitals take care of. So it's not a small amount. And then additionally, a lot of the Medicaid insurances that are taken at large hospitals, they don't pay enough to the hospital to even pay for what care was provided during that hospitalization. So the hospitals are losing money there, and then they're forced to make it back on the commercial insurance. Let's change gears. So we've talked about the hospitals, right? So the hospitals are billing more money to try to get more out of the insurance, and there's a battle going on there. But we need to step back and we need to talk about the insurance, because the insurance companies, they're doing the same thing. They want to keep their costs under control. And as we talked about in a previous video, they do want to see costs go up because they get to keep a percentage of overall costs, but they want to keep costs under control. So they've put together their own bureaucratic army to fight against all the auditors, billers, and coders within the hospital. And then hidden within this entire matrix are something called PBMs. They're called pharmacy benefit managers, and they are what we call the hidden toll booth of our medical cost system. Let's step back to the beginning of PBMs. This is in roughly the 1950s they started. Their job was to make sure that when you went to the pharmacy and you bought your medication, that you would then get reimbursement from your insurance company. Initially, back in the day, when you went, you'd pay with cash, and then you would submit to your insurance company for reimbursement. And then the insurance company may reimburse you several weeks later. The pharmacy benefit managers made sure that this process was done much quicker. So it was a small administrative force that did this. Well, they've expanded way beyond that now. So there is a corporate, what I call triopoly here, of 3 different companies that basically are the PBMs for over 80% of all of prescriptions in the United States. This is CVS Caremark, Express Scripts, and Optum RX. And the big lie that they tell people is that they are there to negotiate lower drug prices. This is not true. This is a scam. And they do their scam via 2 different methods. One, rebates. So rebates are a way for the PBM to scrape money off the top from the individual. The PBM acts as a middleman between the drug manufacturers, the insurance, and the pharmacy. The PBM will go to the drug manufacturers and say, hey, we can get you your medication on the formulary for this insurance company. But what you have to do is you have to offer us a generous rebate. And what a rebate is if the cost of the drug is, let's say, $50 per month, and they give a rebate of $40 per month, then the PBM will actually take a portion of that rebate and pass the rest of it on to the consumer, to the customer, right? So if they say, we'll give you a $40 rebate, then they will charge the customer, say, $30, and they get to keep $20. So they tell the customer, hey, instead of getting your medication for $50 per month, you're getting it for $30, when really they could be getting it for $10. The problem with this is it incentivizes prescription prices to be higher with bigger rebates because it allows them to make more money off those rebates. The second thing that they do is something called spread pricing with the pharmacies. So I said how the PBMs are the middlemen. The PBMs will go to the pharmacies and they will say, hey, we are going to connect you with the insurance, and for this medication, we are going to pay you $10 per month. You provide it for us. And the pharmacies will say, okay. And then they go to the insurance company and they say, hey, we're going to charge you, you pay us $100 per month, and we will get that medication to your customer. So the pharmacy is getting $10. The insurance is paying $100. The patient is getting the medication, and the PBM is keeping that $90 difference. And that's the big thing that is such a scam here that no one realizes is going on. Let's step into the next logical question. Why not get rid of these PBMs? Why not just have the pharmacies work directly with the insurances and cut the PBM out of the middle? That's because they're all the same companies. They have created vertical monopolies with essentially three companies throughout our country. The first one, and probably the most well known for doing this, is CVS Health. So CVS Health owns Aetna Insurance. They also own CVS Caremark, which is the PBM, and then, of course, CVS Pharmacy. So whenever they say that Aetna Insurance isn't making that much money, but the PBM is making a ton of money, CVS Health is still making a ton of money at the end of the day, right? So it's a way to say that the insurance is doing the best they can do when the PBM is making all the money. The next one is Cigna. Cigna, obviously huge insurer. They own Express Scripts, who is the PBM in the middle. They don't own the pharmacies, but just by having those two, they get way more leverage. And then finally, there's United Health Group, which of course everyone knows. They own United Healthcare, which is their insurance, which then they also own Optum, which is the PBM. So you've basically had 80% of the country is being exploited by these verticalized monopolies that at the end of the day, they need to be broken up by our government. But of course, they spend a ton of money on lobbying. So we've talked about a lot with the hospitals marking up these treatments, the insurance companies battling back and forth with them, creating this arms race of administrators that's driving up costs. We've also talked about PBMs. All of this fits in the idiot index because it's that hidden chunk that takes that multiplier of $1 bag of saline costing $150. And how is the hospital not making any money? It's because of all this fat in the middle that we talked about. The arms race between the administrators at the hospitals and the insurance companies. And then you mix in the PBMs and the pharmacies in there, and you get this huge chunk of money that no one knows where it's going, but it is going to these corporations. And it's not beneficial for us as consumers, and it's not beneficial, honestly, for our society. I'm being very critical of these people for good reason. And then, of course, I could always look in the mirror and say, well, what about physician pay, right? Physicians have to cost a lot of money. What about all the clinical staff that goes into healthcare? That has to cost a lot of money too. As it turns out, if you were to make physician pay $0, it would save about 8% of the total cost of healthcare in our country. Additionally, if you were to pay all of the clinical staff, that includes nurses, nurse practitioners, physician assistants, medical assistants, all the therapists involved, they only make up 10 to 12% of all healthcare costs. So the people who are actually administering the healthcare only make up roughly 18 to 20% of the costs of all of healthcare combined. It seems crazy to me. So how do we fix it? Well, if we have large corporations that are monopolies, they're lobbying to politicians who are then supporting them and allowing them to continue to do what they do. What do we do about it? Well, there are things that we can do about it as individuals. We can start with direct primary care. So direct primary care eliminates the middleman entirely. Usually direct primary care clinics can be $50 to $100 per month. They allow for unlimited visits and much longer visits. Direct primary care doctors, instead of having patient panels of over 2,000 patients, can have patient panels of around 400, 500 patients. And so it eliminates all this bloat in between, and it just takes the patient, you hand your money to the doctor, and you get the care. There's also a second thing we can do, and that's cash pay diagnostics and treatments, right? So we talked about that with the story that I had about the patient getting the MRI. You can go into pretty much any imaging place. You can go into pharmacies. You can even, shop around for different surgery centers that can do procedures with cash pay. And oftentimes the cash pay is substantially lower. Third, there's skipping the PBM cartel that we talked about entirely. And Mark Cuban is actually kind of the model for this with his new company called Cost Plus Drugs. And Mark Cuban, he decided that this is a massive issue in our country. He wanted to address it. So he created a company that's called Cost Plus Drugs, where the cost of your medications, it's all cash pay, it skips the insurances. The cost of the medications are whatever the manufacturing cost is plus 15%. And that 15% is basically going towards running his business. And then finally, on a company wide scale, because a lot of the companies that really suffer the most from the expense of insurance are small and medium sized companies, they can actually switch to directly funding their direct care integration, right? So they can, a lot of times, they'll put together a fund that where they hire a direct primary care group, or maybe even get access to a direct specialty care group where they can have their employees and their family members be taken care of with cash pay prices. And then they wrap an umbrella coverage around that is for catastrophic hospitalizations with high deductibles. So as long as you don't have anything really bad happen to you, you can get all your routine care done with cash. And this is often much cheaper for the companies. So those are four things that will help cut the middlemen out. But at the end of the day, what do we need to do with the hospitals and how they're battling with insurance? I think this is like the Cold War. We need demilitarization. Okay. The way we can cut costs here is by getting rid of all that administrative bloat, or as much of it as possible, which means you need to stop having the individual hospitals and the individual insurers constantly fighting each other, making it so they need more and more administrators. The way we do this, well, there's a few ways. So the first one would be something called a centralized claims clearinghouse. So this would allow claims to be processed through one standardized clearinghouse. This was done in banking before. I mean, imagine if each bank handled transactions individually, things would get messy. Banks would have these weird agreements with one another. Our country said, none of that. We're going to set up a central clearinghouse to allow transactions to occur between all banks. You can do this with insurance. It's just not happening. So right now, all insurances handle their own claims. It's a messy process. You even have some insurances that will hire people like Evercore to administer those claims. It's not good. It's a mess, and it needs to be centralized into one smooth system. The second thing we can do is real-time adjudication of claims. So instead of submitting a claim, say your doctor orders a procedure or orders an image, and then it has to go, it has to sit, you wait for it to come back, you wonder if it's approved yet. A lot of that can be done real time. And there has been the technology for a while, and especially now with these AI tools that we have, you can have a submission occur, it runs through the system and immediately kicks back and tells you if it's approved or not. That needs to happen. It would make things much faster. It would eliminate a lot of the administration of checking to see if insurance authorizations have come through. Third thing, even more aggressive, if you want to be aggressive towards the insurances, is you could do a denial penalty tax. So I imagine you've heard by now, insurance companies want to delay and deny care. Well, the way you fight back against this is you penalize the insurance companies if they deny care that is deemed necessary. What you do is you require third parties to do the appeal process. And if they find that the physician was correct in ordering that procedure and that it should have been approved, then the insurance company would have their denial overturned. And not only would they be responsible for covering it, they would actually have to pay more to pay for all the lost time and all the administrative process that needed to happen because of the incorrect denial. So that's for the insurances. But what if we were to be a little tougher on the hospitals? And I think the way we could do that is by having all payer reference pricing. So we have cash pricing. All hospitals are required to make their cash prices available. We should have all payer referenced pricing. So basically every insurance company would pay the same thing. Right now, there's just entire teams of people with hospitals and insurance companies that are negotiating what rate they're going to pay. And with this, the hospital can just say, hey, we set one standard rate. If you want to cover your customers coming to our hospital, then you just have to pay this rate. And this would take care of all that negotiating and all that back and forth. All right, that's it. That's the episode. So I know it seems complex. I know it seems like there's not a lot that we can do on an individual level, but really there is. And especially if you're someone that is part of the process of picking what health insurance your company has, or even if you're a smaller, medium sized business owner, you can start taking things into your own hands. And then at the end of the day, we need to support the officials in our government that are actually going to hold these companies accountable and start putting in some of these changes that I talked about. I would love to hear down in the comments if you have any better ideas as to what we could do. As always, I'm Dr. Nolan Fisher. This is Second Opinions. I'll see you next time.